Hi, my name is Paula Ray, and I'm a pediatric neuropsychologist here at Madonna Rehabilitation Hospital. And some of my other credentials, I'm a brain injury specialist, and I do have infant mental health specialization certification. So the rest of the panel will introduce themselves.
Hello, my name is Jeff Steck. I'm the Pediatric Program Manager. I'm a speech pathologist, and I've been the Pediatric Program Manager for the last 2.5 years.
My name is Sarah Economides. I'm a physical therapist here at Madonna on the pediatric team. I'm also a board-certified pediatric specialist and a child passenger or child safety technician.
My name is Pam Daly. I'm a registered respiratory therapist on the pediatric unit, also a brain injury specialist and pediatric advanced life saving.
My name is Sarah Messerly, and I am a speech language pathologist on the pediatric team as well as a brain injury specialist.
My name is Kelly Myers. I'm an occupational therapist on the pediatric team. I'm also a brain injury specialist and a child passenger safety technician.
So our hope today is that we would be able to identify the prevalence and incidence of traumatic brain injury and the comorbidities that influence a patient that sustains a traumatic injury, whatever influences their rehabilitation. We want to identify some family-centered intervention techniques that we use in pediatric rehab and apply our clinical reasoning and demonstrate how that clinical reasoning kind of evolves with some case presentations. Additionally, we are going to be discussing the Ranch Los Amigos levels of brain injury and some strategies for appropriate interaction at that time. Traditionally, our population as a pediatric population is really thought of as children that have sustained an injury, such as traumatic brain injury or spinal cord, stroke, etc., as well as those children that have congenital differences, such as autism or Down syndrome, for example. So when we're talking today, we are going to be specifically thinking about children that have sustained some acquired injury following what we would presume as a typical birth or a very functional start to life. Just to kind of give some context, pediatric stroke, statistically speaking, is about 2.4 children per 100,000 live births. Spinal cord injury is at about 5, almost 6 children per 100,000, whereas pediatric traumatic brain injury is 70. That 70 is then broken down additionally when you look at the Center for Disease Control figures, and 14.7 children are born with abusive or have abusive head trauma, sustained abusive head trauma, in that per 100,000 live births. 26 are typically in the first year of life, and 3.5 are often within the second year of life. The highest incidence is broken by 0 to 4 years of age, 15 to 19 years of age, 65 years and above, 30% following traumatic brain injury expire. There's a number of statistics that identify the cost. Annual cost is estimated at $60 billion. Lifetime cost is $406 billion. So those numbers are pretty staggering when you think of the financial impact that pediatric traumatic injury means to a child and means to their family. When we think of pediatric traumatic injury, we think of the initial mechanism or the first degree injury. So that's when there's a mechanical force or the actual trauma that occurs, and then there are secondary complications that follow. And those are typically the things that we are managing in addition to that primary level of injury. But you'll hear us talk as we move forward here about some of those different mechanisms or different disruptions. So there's a mechanical force and a shearing deceleration and rotation that may occur to the actual axons of the brain. That's the initial trauma that occurs. Those secondary complications, such as edema or seizures, excitotoxicity, those types of things are always managed in addition to those primary causes of difficulty for children. So again, diffuse axonal injury, or that disruption or tearing of the vessels, creates then a focal source of injury, contusions, lacerations. Children sustain those injuries because of a coup, counter-coup, or it's either a closed injury or an open injury. Secondary injuries are described also by saying that a child would have a hypoxic ischemic encephalopathy, which would result in systemic problems, cardiovascular, respiratory compromise, etc. Swelling and edema can result because of elevated intracranial pressures, or the tearing or herniation that is occurring physiologically. And then there's electrolyte imbalance that can also be a secondary complication that is also managed in a rehab stay.
And one of the things that some of you might not be familiar with is some of the terms that we use to describe different types of injuries. And Jeff just mentioned one that I think a lot of you on this webinar may have had exposure to, and that's more anoxic or hypoxic injuries. And those really have to do with incidents where there's choking for some reason or another. There isn't enough oxygen that goes to the brain. And the difference between hypoxic and anoxic has to do with the amount of lack of oxygen. So a hypoxic injury might be something that is a little less severe than an anoxic injury.
So when we think of abusive head trauma, we're often talking or primarily thinking about children less than 2 years of age. The majority of those children are less than a year, actually. More often it's males than females, and it's estimated 600 to 1,400 cases per year. Abusive head trauma is when there's a shaking incident, usually, that rapid deceleration of the head that impacts, so the brain will impact the internal skull, and that's that coup, counter-coup again that we were talking about earlier. So those events then cause subdural hematomas, direct trauma to the brain itself. Retinal hemorrhages are also identified during or because of those types of abuses as well. So the pathophysiology that occurs is that the veins that bridge from the brain to the dura, which is some of that anatomy of the brain, those are actually stretched or torn, creating that bleeding, and then the pressure builds in the subarachnoid spaces of the brain. Because of that shearing or that pressure, then those axons tend to move and shift and tear or shear, as we say. The lack of oxygen, as Paula was referencing, the anoxic injuries cause then those irreversible type levels of damage that are really characteristic of our traumatic population. So you have this mass traumatic destruction of the brain tissue that creates the swelling and increased internal pressure. And then those problems then become more compounded in terms of the overall management of these children.
And I think another area that people always ask who may be working with children who have had an early brain injury in different settings, in a school setting or in a community setting, is, well, what do we expect from these injuries? And it's important to remember that some of these we're talking about, like if there's bleeding actually on the brain tissue, that can actually destroy tissue. So you're going to see more pronounced long-term consequences or disabilities that are, there's just a level that they won't recover from. Neuroplasticity is a concept that we'll talk more about, and that has to do with how areas of the brain do heal and how some of the interventions that you'll be hearing about today really help that process and help children regain some of the functional skills that they might have otherwise lost. So it's a continuum. And I think that that's important to remember when you're ever working with a child that has had an early brain injury, is to, even if they look okay, not necessarily to to think that everything is okay and recognize that there may be a need for continuing monitoring as the child develops, as well as never to give up hope on the functional gains that a child with a severe brain injury can accomplish.
And some of those areas that we like to really focus on and think about in terms of recovery or influence, what is it that you all will influence, what is it that we try to influence as a child continues to evolve or change. So there's physical motor deficits that occur. How well they balance motor processing, the tone and spasticity that is occurring because of that injury. So those are things that are noticed fairly quickly and then continue to monitor. Cognitive and deficits, which include attention, memory, executive function, behavioral challenges, those can all be secondary complications to the TBI. Communication and feeding deficits, which we'll talk about in a bit more detail, and how a child is able to communicate as well as manage the oral structures so that they can eat and communicate. And then sensory deficits as well. Visual, olfactory, hearing impairment, etc. A recent study was done, and approximately 21,000 children, or a little over 21,000 children, were looked at following admission to acute care. So when we think about children, we think about an acute level of care. So they have the accident or injury and they go to the hospital, and that's the acute level of care typically. And then following, once they become essentially stable, then they move to an acute rehab stay or home to discharge. The level of intensity and the type of interventions that are provided along that continuum of care really do influence their overall outcomes. So a recent study in 2013 was completed, and during the acute phase of care, children that were admitted to the hospital with a traumatic brain injury, 41% received an occupational therapy or physical therapy evaluation. 26% of that population, that 21,000, received either a speech evaluation or a swallow evaluation. What's interesting to note is that their first evaluation was on day 5 for OT or PT, occupational therapy or physical therapy, and as late as day 7 for speech or swallow evaluation, which is not to say that acute care is too slow, because what's happening is that child is very sick. They're trying to stabilize them for a variety of reasons. So there's a lot of rationale as to why those would possibly be some delay. The significance there is that if you are trying to establish a rehab plan for somebody, you need to have some of those baseline levels of information, those assessments, so that that can be done. And that's something that is an ongoing challenge. So why is rehab important? Well, many children are presumed to grow out of it or develop in a way that once they get home, everything will be fine. And so the complication to that is if you're managing poor attention and poor ambulation and a sensory system that's now changed because of an injury, trying to kind of keep all of that in check while you rehabilitate or recover is challenging for adults and also for children. So if we can get them to a level of intensive therapy and support, we feel it's in their best interest. Multiple resources that are included in the PowerPoint are just identifying why rehabilitation has had a dramatic impact on functional outcomes for children. It's a takeaway point, really, that the more intensive and the quicker a child transfers to a rehab process, the more functional their return is going to be. We would argue that that rehab process is an inpatient rehab center. So.
And I think that one of the things that we all keep in mind is when we talk about rehabilitation for children that for children very young, as was mentioned in the slide earlier, children 0 to 4 are one of the highest risk group for traumatic brain injury. And these are children that we see in a medical rehabilitation setting, that are seen in early intervention that are then seen in the school systems. And when we think about rehabilitation, we need to think in a global sense. And it isn't parceled out where a child would get services in one place or another. The best approach is comprehensive across context rehabilitation that in all aspects helps the child to function to the best of their ability. One significantly important component, a core principle in pediatric rehab, certainly in a medical setting and an educational setting, but the whole idea of family-centered care is really basic to medically based pediatric rehabilitation. And family-centered care is made up of a set of values and attitudes that really define the approach that team members take in working with children and families in pediatric rehab. And the concept of family-centered care really emerged from some research that came to light about some of the negative effects that physicians recognized when hospitalized children were separated from their families. And initially that was the model that was used. Children in a medical setting were treated separately from their families. And after some studies showed that really that didn't prove to be in the best interests of the overall child's rehab, that in fact the children that were with their families did a lot better. And those findings combined with fundamental theory around attachment that really shed light on the significance of the parent-child relationship and the understanding that a child cannot be separated from their family or from their primary caregivers and not seen as just part of a family unit. That theory combined with the results, the negative results that were seen in medical settings when children were separated from their families, really informed this whole development of a concept called family-centered care. And some of the principles around that underlie family-centered care involve in knowing that the parents and caregivers are the most important people to that child, that those are the people that know that child in a way that therapists and educators and those of us that are 1 and 2, 3 steps removed will never really know the child. And that it requires people that are working with children to have a full respect of families as being integral and co-equal parts of the rehabilitation team. That it's not information that they're given secondarily or that their opinions are considered only after the medical opinion, that it's the priorities and the information that the families and parents have about their children is woven into the treatment process every step of the way. So family-centered care certainly recognizes that each family is unique. A family is a family is a family, and it's defined by who that family is. And that it recognizes that the family, again, is the constant in that child's life, and that the primary caregivers are going to be in a role with that child to be the child's advocate. Once they leave, for instance, a medically based rehabilitation center, they're going to be the ones that are going to transfer that knowledge and that information about the child's progress to the next group of professionals that will be working with that child and the next and the next. Some of the benefits of family-centered care involve that there's a real consistent care. Well, the consistent care of a responsive, attuned parent can really buffer the impact of trauma. And those of you that work in the field of early childhood mental health are well aware and steeped in some of these concepts. That it's the attachment relationship with the caregivers that's going to help that child develop the resiliency to be able to deal with whatever limitations in their functioning they may be experiencing, to weather the demands of medical interventions, of therapeutic interventions. And that a responsive and attuned caregiver really is the safeguard around the child's optimal development and adjustment, regardless of what their functional limitations may end up being. So the benefits that we see are that it improves the quality and safety of a patient's care, because families value of family-centered care really helps to foster communication between families and healthcare professionals or any other group of professionals that are working with the family. And the families feel comfortable working with professionals when they feel heard and seen and understood. There's an interesting study that came out of the University of Virginia Children's Hospital, and a study found that sharing information and involving the family in patient care resulted in not only benefits to the patient and the family, but a rise in staff satisfaction. That there was improved consistency of information given to family members, and that there was a significant rise in overall patient satisfaction scores. So fundamental to family-centered care and pediatric rehab is the whole idea of pediatric team building. And in a family-centered care model, parents are involved in the team. While they might not meet at every team meeting where the goals and the interventions are discussed and where the medical status is discussed, there's always parent involvement. There's always a lot of communication back and forth. And pediatric team building really, in a family-centered model, recognizes that, again, the parents are the experts of their child, and that the parents are the most important people to the child. A multidisciplinary or transdisciplinary model is often what we use here, where therapists share with one another, communicate regularly, sometimes talk across disciplines, sometimes share a nomenclature that is inclusive of all the disciplines, keeping in mind the simple goal of helping the child function to the best of their ability. So I'm going to turn the next section over to my colleague Sarah, who's going to discuss some of the nomenclature around brain injury and pediatric brain injury.
So one of the things we think about when a child has a brain injury is how do we classify that or characterize what we're seeing and observing and how severe the brain injury is. One of the scales we use is the Rancho-Los scale of brain injury, and it goes from a 1 to 10, and we'll just review that a little bit. So Rancho levels 1 through 3 are pretty similar to each other. Level 1 is basically the child or person with a brain injury is in a coma. You're not going to see any response no matter what stimulation might be provided. Level 2, they're starting to wake up. Maybe their eyes are open, but you're just getting a general response. They're not able to follow commands. You might get the same response no matter what stimulus you see, whether that's an increase in a heart rate or agitation or tone or spasticity in response to light or touch or noise. Rancho level 3, we're starting to now finally get some localized responses. So if you ask them to open their eyes and blink, they might do that. It's going to be inconsistent at first. They're starting to follow some of those commands. Squeeze my hand, lift your head. They might be able to either verbally or with the thumbs up or down answer some yes/no questions inconsistently. One of the things that at these stages, a person with a brain injury is physically dependent. They're not able to move themselves. They're in a bed for all mobility and self-care. So getting dressed, eating, all those kind of things, they're completely dependent. When we move on to Rancho level 4, this is one of the most challenging states that we see in that level of recovery, because at this stage the person is very confused, they're often very agitated, they can also be physically or verbally aggressive, swearing or hitting people that are trying to help them because they don't understand what's going on around them. They have no ability to recall information that they're taught, so short-term and long-term memory is impaired at this state. They don't have any awareness into their deficits, and no safety awareness, so physically they might be trying to move themselves, but it's very high risk for falling down, injuring themselves as well. For younger children or infants, this can be a really challenging state as well, because a lot of times they maybe weren't talking or only had a few words in the first place, but this can kind of manifest as inconsolable crying or just constant fussiness where they have no other way to express themselves besides crying. When you think about physical mobility and how well they're able to participate in the daily routine at this state, it kind of is somewhat dependent on what other comorbidities or what other injuries they sustained during an accident. If they didn't have any physical limitations, so no broken bones, no weight-bearing restrictions on an extremity, they may be able to physically move but might need 2 people in order to keep them safe. But if they did have a broken bone or something like that, they may be completely dependent for all mobility. It's a wide variation of what we see at that Rancho level 4. As we progress up the scale, Rancho level 5, people are beginning to calm down. They're not quite so agitated, but they're really only able to sustain attention for a very short amount of time, maybe 5 minutes. They're still very confused and do not have the ability to recall new information, very distractible. Working on getting language going, they're often very confused with how they're expressing themselves as well. Rancho level 6 and 7, that agitation phase has calmed down. Still confused, but maybe more consistently orienting to who they are and where they are and maybe why they're in a hospital or what happened to them. Still a very flat affect. They're not going to show much emotion and not understand abstract principles. So any instructions that are given need to be concrete instructions, one-step commands, those kind of things. They're still going to have very poor memory from day-to-day perspective, but maybe long-term memory is less impaired at this point. As far as functional mobility and participating in their daily routine, at this point, through that Rancho level 5 through 7, a person is progressing from maybe maximal assist initially at that level 5 up through standby to min assist for needing help with balance, with safety awareness. That is still a significant deficit, lacking insight into their deficits that they have. Beginning to be able to do more with dressing and eating and needing some support to complete those activities, but getting better. As we move to the top range of the Rancho scale, levels 8 through 10, we're getting to be much more normal on the surface, especially at level 8. If you were just to have a surface conversation with someone, you might not know that they had a lot of deficits or had a brain injury. They're going to be more independent with familiar activities in familiar places. They can recall more day-to-day events. They can plan for the future. But unfamiliar situations, going to the mall or back to school, environments that are very open and distracting are still going to be challenging. Rancho level 9 and 10 are pretty much back to normal with maybe some slow processing and a little bit of deficits with maybe safety or their awareness into their deficits that they have. That is, they've regained that awareness, but sometimes you'll get emotional disturbances or depression because of that, and they're realizing things are maybe different than they were. But physically, at this point, most people are completely independent. They're able to plan their day-to-day activities. They're able to do dressing, eating, bathing, and beginning, especially at Rancho level 10, back into those instrumental activities of daily living. So working, driving, and getting back to work and back into their activities that they used to do. I'm going to pass it on to Sarah Meserly, our speech therapist, and she's going to outline some strategies that we use for the different interacting with people at different levels.
And one thing also to consider with the Rancho levels, it is possible for people to kind of get stuck at different levels. And so these are strategies that can help people kind of progress through them more quickly, depending on their severity of injury and maybe prior level of function. For all levels, it's important to include personal items to facilitate functional responses, especially at levels 1 through 3, using calm, slow speech, speaking clearly and using simple language, and then providing orientation information, what happened, where the person is at, who you are if you're someone new, and also provide the person time to rest because their brain is healing and it's very important to get that rest time. At that level, you also want to allow up to 30 seconds or more for responses because that person's brain is trying to process information as well as complete what you're asking them to do, so you might need to offer them more time to respond. For strategies for level 4 and 5, Like Sarah said, this is a challenging level because people are agitated and can be aggressive, and family members sometimes have difficulty with this because they're often receiving that aggression. So it's important not to argue with people going through this, so try to avoid those arguments, have familiar people around, have a calm environment. You might turn the lights down or go to a quiet room, and then provide gentle praise and physical and verbal reassurance to make them feel better, and also provide that orientation information where they're at, because at this stage people are very confused. And then allow frequent breaks as well at this time. And then strategies for level 6 to 7. Utilize a journal for memory and daily recall. As people are going through this, they start to be able to remember at about this stage, and then using memory strategies can help progress that more quickly. You can talk through different problems in areas of cognition. At this stage, people don't realize that they are having difficulty with cognitive tasks, so talking about those impairments they might have and things they can do to get through that is important. And then you can review those things from memory logs at the end of the day, and then at this stage continue to provide orientation information, which can also be included in some strategies such as a memory log. And then Rancho levels 8 through 10, you want to continue to talk about maybe impairments or difficulties people are having, especially with higher level cognitive tasks. At this stage, people, like Sarah mentioned, they might look completely normal. You would never guess they had a brain injury, but once you talk to them or they start trying to work on some problem-solving things, then you realize that they're still having difficulty with that area. And people become more depressed, so you want to provide social support. It's important to have some peers to work with them, so they'll continue to have good social support, because going back to school, they might not be able to make new friends as easily, and it's more difficult to keep their old friends. So it's important to always have those social supports around. And then I will pass it on to Kelly to talk about prognosis.
So prognosis is a really common question that we get. Families want to know what's going to happen to my child, how will they turn out, what is going to come of this. And it's a very difficult question to answer because every child is so different. Outcomes and rate of progress, and even what progress means, is different for each child. For one family, progress could mean my child smiles at me. For another family, it could mean that they are up and walking. And other families want that child to go back to everything that they were doing before. And it's really a difficult question to answer because recovery can occur for years. And with children, we must consider their development and the transition to different ages and stages in the relation to their injury as well. Other things to consider are the family support, what environment were they living in before, what environment will they be going back to. So there's multiple things to consider when we think about prognosis. But we do know, based on some research, that there are some certain factors that you can look at related to prognosis. One area that you can take a look at is the location of the brain injury. Lesions in the brainstem tend to have worse outcomes than lesions in the cortex or the white matter. And diffuse injuries, so as Paul mentioned, the anoxic or the hypoxic injuries tend to have more difficult outcomes because, or more challenging aspects to that recovery because of the diffuse or the global effects on the brain. The type of injury is another factor to consider when you're thinking about prognosis. Subarachnoid hemorrhages, significant midline shift, epidural hematomas, subdural hematomas, cisternal effacement all had worse outcomes in the research that they did. Another factor would be the Glasgow Coma Scale. This is a scale that's done usually right away, and the lower the Glasgow Coma Scale, lower scores were associated with worse outcomes. But it's important to keep in mind, especially with this one, that you can't draw specific conclusions from the Glasgow Coma Scale alone. And with a lot of these, you don't want to just take one aspect. You want to kind of look at all of these factors as you're looking at prognosis. But certainly a lower Glasgow Coma Scale was a worse indicator. Additional factors include length of coma. The increased length of coma, the more likely for a worse outcome. So if someone is unconscious for 1 month after a traumatic brain injury, they have about a 50% chance of regaining consciousness. Post-traumatic amnesia is another factor associated with prognosis. The longer the duration of post-traumatic amnesia, the worse the outcome. So the longer that somebody is kind of out of that, not understanding and not remembering those things, the worse the outcome. But a good prognosis is expected when the post-traumatic amnesia is less than 24 hours. Bad prognosis, more than 7 days. Age is another factor. Older patients have worse outcomes after a severe brain injury. Pediatric patients tend to have better recovery than adults, but they may have worse long-term functional outcomes due to the effect on learning and development. So, as I said earlier, every child is different, every situation is different. Other things to consider include storming or dysautonomia, where the brain and the body are just not able to handle stimuli, and they're having lots of effects with tone management and posturing. We'll see this when we talk in a case study later about Molly, that she had a lot of tone and posturing. There's different types of posturing. Decorticate posturing is more of a flexed posture. Cerebrate posturing is more of an extended posture. You can see variations in those things, or variability from day to day. Hopefully you see improvements in that as they continue to recover. But posturing is not a great prognostic indicator, and especially if that lasts longer, it's not a good prognostic indicator. Opsoclonus is another thing to consider. These are rapid, irregular, non-rhythmic movements of the eye in horizontal and vertical directions. That's a poor prognostic indicator. And then again, the non-traumatic injuries like the anoxic encephalopathies, those types of things are also poor prognostic indicators.
Can I ask you a question on some of the terms that you were describing? I'm just wondering if maybe the team could just say a little bit more, just to clarify some of the definitions of terms that we're using. Significant midline shift. What is that? What does that mean?
Sure. So a midline shift, when we look at a brain, we have two hemispheres on the midline. So if we've had an injury that shifts that tissue over to one side, we get a midline shift, and it just is a shifting of that tissue. That can be a prognostic indicator.
And is that something that heals? Does the brain go back into a more normal position?
It can, depending on swelling and other issues, it can. Or it can be an ongoing issue that can affect vision and balance and all those areas that we talk about with brain injury.
And what's a cisternal replacement? Some of these are terms that, and the reason why I'm asking is that people may be reading information about a child in a different setting, and some of these terms, if they're a little more understood, I think in general, if I were in a community setting and want to know, well, is it severe? How severe is it? What's the prognosis? And how can I, in my setting, kind of get a feel for that?
Yeah, I think a lot of these things, as you're looking through the literature, there may be things that you don't understand or things that you're not sure of, but being, kind of getting your feet wet and looking at that information can be helpful. There are a lot of technical terms out there, but there are a lot of resources out there to help you find information on those things that you need to look up as well.
And effacement just is really talking about kind of a stretch or areas or pockets within the brain that are stretched and pulled. And so anytime that tissue is positioned differently because of some sort of injury like that, it can cause some of that trauma or some of that damage. So those are those secondary complications. So that shearing, the midline shift, all of those are considered secondary complications because of those differences. So.
And an area where if you have questions, you could always log on to the Nebraska Brain Injury Association, which has a lot of information about brain injury. So a little bit about why we talked about rehabilitation being significantly important with pediatric population. And what we know, part of the reason for that is that the largest amount of brain injury occurs within the first 5 years of life and is as we know, that means that the foundation is not complete. So when a child has a brain injury, development can be altered because there are aspects of the brain that just have not developed yet. So functional skills are not yet in place, which is different from an adult brain injury where structures have developed, functions have formed, and sometimes there's a compensatory ability that adults have to regain some of those that, again, a child might not have because they haven't developed those skills to begin with, or the neural foundation for them. So acute rehab post-injury is critical in providing the stimulation that's really needed to maximize their recovery, as well as really to encourage new neural networks, new neural pathways. And interventions provide the extra support that's needed for this continued development to form, so that if there are areas of the brain that are related to a certain aspect of functioning, the interventions can really be designed specifically that will challenge and help the new neural network to form, to compensate, and to regain or to develop some of these abilities. So it's really important in understanding TBI in the pediatric population to be a developing disability. And that is something that with intensive rehabilitation we hope to minimize. And the concept of neuroplasticity is critical in the work of pediatric rehab. And basically neuroplasticity, and I know many of you have heard this term and are aware of it, it's the capacity of the nervous system to reorganize and to create new connection in response to stimulation, to specific stimulation. And there are critical periods of neuroplasticity that occur in childhood. And so, in the first, let's see, the first 3 years, the frontal lobes and the parietal lobes are forming. An injury at that time might look a little bit different than, for instance, if those aspects are formed and a child is 5 years old, and there's different areas of the brain that are forming. So two similar injuries occurring at different times in development really can create two dramatically different outcomes. So it's important to know that, and just there is no specific profile, for instance, with a child who's had a brain injury where you can say, well, 5 years down the road, they may look like this. In rehabilitation, interventions really influence the reorganization and the building of these new circuits following an injury because of they're very task-specific as well as intensive with mass practice. So those are the key concepts in neuroplasticity that in pediatric rehab following a brain injury that are kind of core guiding principles. So what contributes to success? Well, a strong multidisciplinary team. And a team is made strong by regular communication, by daily team meetings, consistent approach to skill acquisition and refinement. So the team, for instance, may come up with a set of overarching goals that are established for this particular child, and then each discipline implements that within their own frame of their skills and training, and yet the overall picture is one that's integrated and helps the child reach their highest level of functioning.
That team may be a team that is on site. So if we have a child that's with us for an inpatient length of stay, let's say, that team includes everybody that's on site. But if a child is getting early intervention service, or if a child is getting outpatient services, for example, there's a virtual team, if you will. So there are primary care physician, there are levels of subspecialty expertise that are influencing the development and skill acquisition for that child. All are essentially what we mean by a dynamic and strong team.
And which leads to one of the key aspects of what contribute to the ongoing success is a comprehensive discharge plan, where it's understood that there's the next team that's going to come in, and there are other players that will make up that team. That it's never ever well, it's a vibrant and changing team is who the child and the family is going to be interfacing with throughout the child's development. And each member, at each stage, what's a critical component in understanding is for members to have a firm foundation in what's normal development, so that when red flags are seen where something is atypical, that information is understood within the context of, as was mentioned earlier, pediatric brain injury being understood as an acquired developmental disability sometimes.
And I think it's important to just kind of differentiate a bit. When you think about an adult that has sustained a trauma and they're recovering those skills, just like you were mentioning, Paula, where they relearn or rehabilitate skills that have been previously acquired. That's different for the pediatric population because they're just now learning skills. So you're going to rehabilitate skills that they've already mastered to some degree, but you're also setting the foundation in place so that they can habilitate or learn new skills as they move forward. So
the focus of rehabilitation with infants and young children is around motor development, fine motor development, gross motor skills, feeding and swallowing, managing muscle tone, spasticity, range of motion management. So that, again, so that the infant has intention and the child has more intentional control of their body movements. That's very integrated with sensory processing, vision, auditory, some of the body senses that will be discussed earlier. All of those make up positioning, how well the child can then not only intentionally move their body, but access aspects of their environment, how they sit, where they sit. And then some of the higher level skills, language, cognition, communication. So what we're going to do now is move into presenting you with some cases that will illustrate some of the points that we've been talking about. So Jeff is going to introduce Molly.
So this is going to be a little bit more interactive and informal in that we're going to be talking through some of the clinical reasoning around these two children that we're presenting. So like Paula said, Molly is our first case, and she was 2 years of age at admission and sustained an anoxic brain injury. Molly had lodged a hot dog in her windpipe, and they started CPR on site, but eventually she required a trach, and she sustained ischemic encephalopathy following that anoxic event. She had significant cognitive and motor deficits sustained following that event, and at time of admission, her dysregulation, her autonomic dysregulation was substantial. She had a hard time calming and quieting to sustain or tolerate the therapy that she was needing. She entered our facility at a Rancho level 2. So as Sarah was talking about, she's pretty quiet at that point then.
Molly had a lot of difficulty tolerating any kind of stimulus, so someone would walk into the room or turn a light on or talk to her, and she had a lot of tone and posturing, and her heart rate would go up, so that general, any stimulus kind of caused the same amount or same response in her. But that agitation, inability to tolerate that activity made it difficult initially for her to participate in therapy, and she was not able to follow commands and all those kind of things.
So she stayed with us a total of 124 days, and her state or her ability to regulate herself was a significant barrier for her. Oftentimes, I think when we are talking about state, we think of it only of an infant. So they're quiet, and then there's like an active sleep pattern that an infant will demonstrate, and then they're kind of drowsy, but then they're alert, and then they're actively awake or they're crying. So what we see in children that have sustained injury and are at that level 4, those kids are on the move. They're very agitated or difficult to console or quiet. So, anything else with that? So some of the sensory needs and the regulation, Kelly, do you want to talk about that a little bit?
Sure.
In terms of how we would possibly approach someone like Molly and some of the strategies that we would use to support her from a sensory standpoint.
So when I look at a child who's agitated or having a difficult time with state regulation, there are multiple things that I do as an occupational therapist to try to help them manage that. One thing is I look at their environment. So when I look at their environment, is it an overstimulating environment? Are the lights on? Is the TV on? Are there multiple visitors in the room? We can change that. We can turn the lights down low. We can turn the television off. We can put in maybe some more calm music into the room. Sometimes we can use scent, lavender or different calming scents can be calming for that child. Again, just the people in the room, the background noise, calming that auditory sensory environment can be helpful for those kiddos. I also look at things like her position. Can I manage her tone a little bit better if I have her in a different position, which can help her calm in a vestibular and proprioceptive sense, or proprioceptive sense being our sense of body and where our body is. Can I make her more comfortable by changing her position or maybe wrapping her in a blanket? So there's multiple sensory things that I can affect when I'm just simply looking at a patient's room and changing some things there. Movement can be calming, head to toe rocking, that vestibular input can be another sensory intervention that can help kids like Molly calm. There's multiple approaches.
And how did you engage Molly in therapy when she was struggling so much to attend?
I can address that. I still remember her swallow study, and she would get, it was a new environment, and she was an X-ray, a modified barium swallow study, and we had to distract her with the iPad by playing Dora, because she loved Dora. And so that kind of distracted her while she was swallowing, and she ended up doing fairly well on it. So sometimes we'd have to kind of redirect her with different things. When she was so agitated, it was hard just using calming strategies like Kelly mentioned. And then also her family, she really liked when her siblings would come and visit. And this was a little later on in her stay, but her brother, I think he fell down, whether it was on purpose or an accident, but she laughed out loud, and I guess she was really this slapstick comedy. But having family around really helps her engage. And we often would use, her siblings would have puppets and do different things to help her attend. And even her grandparents were often there helping out with taking care of her, so they were also helpful in sessions. So it's really nice to have family there, as well as with the family approach to rehabilitation. They're there the whole time. Other times she was struggling to attend, we did different things with vision, like Kelly mentioned, and for communication, she would kind of get agitated when things were hard, so then you could take a break and play a little bit and then go back to what you're really trying to focus on in the therapy session.
Some other things that I would do too to help support that would be just analyzing the task that you're doing, breaking it down to a more simple form. So if you're wanting Molly to follow your direction, your verbal direction, and reach out for something and grasp it and then bring it back to her body, that's actually a pretty complex skill. So how can you break that down, looking at your activity and making it more simple for her? And using multimodal cues sometimes can be helpful, showing her and having the toy make sound and having the toy light up, and then having her do it with your hand over her hand. So doing multimodal kind of things can be helpful as well. They're kind of difficult.
And you mentioned things like tone were an issue with her, and how, now because of the severity of her injury that involved a lot of medical interventions too, and pharmacological, how did you manage, how was that all managed between the medical component and some of the non-pharmaceutical interventions?
Part of it was kind of finding what was going to work best for her. There were times where she was completely out of it and sleeping because of the medication, so they kind of had to find the right amount at first. Trying to get between that really agitated state and she's just too calm that she won't respond too much.
There's certainly a role for medication. Our physiatrist or our rehab doctor helps with the medication and managing what she needs to help with tone management, but kind of still allow her to be awake enough to participate in therapy. Therapists, we can monitor that tone and then let the doctors know, hey, that was better, that was helpful, or now she's so asleep I can't get her to wake up for therapy. There's also some non-medical ways to manage some of that tone and spasticity. We can do serial casting or inhibitory casting where if somebody has a lot of tone, we can place a rigid cast on that extremity, and maybe an elbow is very tight due to tone. And we can stretch, apply a cast, leave that cast on for a few days, take it off, check the skin, stretch again, recast, and eventually we get to the point where we've broken through that tone or managed that tone a little bit. Splinting is another option. You can have a removable splint on a hand that's very tight, for example. So there's medicated and non-medicated ways to manage tone as well.
So these interventions are giving feedback to the brain that it's actually helping with the rewiring so that the motor components are more controlled?
It helps when you have so much tone that you're unable to move, it can develop into a contracture, and so at that point the muscle would be shortened and she wouldn't be able to move that extremity at all. So part of what we're doing with the casting or the splinting is trying to prevent a contracture from forming, but as the brain continues to heal, working with that pharmacological intervention as well, managing both of those things together, we're preventing those contractures but also decreasing the tone to allow then volitional movement as she progresses. And then, moving beyond that point, Molly did eventually need Botox in her calf muscles because she had such strong tone that her feet were always pointed. She couldn't stand. She couldn't get her feet flat because those muscles were so overactive. So the combination of using that Botox and then casting her feet in a normal position was what allowed her to be able to regain that function. And then after that, Botox was used, which is a paralytic agent that lasts for about 3 months or so. Then since then, she hasn't needed any more specific casting. That tone has decreased now.
So I imagine that this also affected the muscle tone of her breathing apparatus and swallowing, and what techniques were used to coordinate, what respiratory therapy techniques were used to coordinate?
Yeah, the tone and contracture certainly affected the way she was breathing, which is the biggest reason she had a trach. She was at a really low rancho level, so she really wasn't, her sensory function was impaired as well, and really wasn't able to have that gag reflex in a normal way. She cried a lot, she was agitated, which would cause a lot of secretions that she wasn't able to handle on her own. So we needed that avenue to keep her lungs clear of secretions. She also had some problems with positioning and in the way she was breathing, and she would breathe pretty shallow as it was, and then with the tones and contractures that made her ventilation even worse. When she went on her left side, she would have some paradoxical breathing. So everyone in OT, PT speech, we all had to be careful about the way she was positioned as far as her ability to ventilate adequately with her trach.
Pam, will you talk a little bit about the downside? Like if she can't fully inflate her lungs, but she's breathing and she's stable essentially, but if she's not fully inflating her lungs, what is the downside of that?
Well, one thing we can do, we do things, we have different treatments and therapies to help her with that. There's a lot of lung expansion therapies. There's also vest treatments that we use to mobilize secretions and keep those lungs open. So, PT does a lot of diaphragm strengthening. So we helped her along her way until she started to increase that rancho level.
So like Pam was talking about, Molly didn't have awareness when she had secretions in her throat that she needed to clear. We would do a lot of co-treats to coordinate Molly's ability to relearn how to cough and how to swallow and manage those secretions on her own. So, for example, in the beginning of the day, after sleeping all night and not moving as much, Molly had a lot of that secretion in her lung, and so she would have a respiratory treatment with the vest shaking to get those secretions out and into the bronchial tubes where she could cough them out. And then physical therapy, we would provide some manual therapy techniques to help her cough that out to get a more forceful compression. Otherwise, she would have a very ineffective cough. She wouldn't do it on her own, and she would require suctioning, which we don't want to have to do because it can cause more secretions to form. And we don't want her to be dependent on that. So working on strengthening the diaphragm to have a more effective cough, also using her abdominals and her other accessory muscles to cough that out as well, using that collaboration between all of those therapies to progress her respiratory status to then improve her overall function, were a few things that we did.
What was the role of the family during this process? I mean, how did they work with things like the PMD and the trig cap?
Well, the family had, they were there all the time, and as family centered care, they were very involved in what we were doing as far as a passing ear valve, which I think we're going to start talking about here shortly. They were educated on the different techniques, and they would certainly help as far as repositioning. We all showed them techniques for when we weren't in the room, and they would do that.
Molly's family was very proactive about following through and asking how they could help. They took a very active role in monitoring her tube feedings and how she was doing with secretions. Once we trained them on something, they were able to continue doing it, which helped provide a really good, solid continuum of care for Molly.
And every step of the way, Molly's family was one that the parents were engaged, the siblings were engaged, they were involved with other families, used psychology services regularly, brought the siblings in so that there wasn't an aspect of this family crisis that wasn't being discussed, so that there was a wonderful sense of support, and the supportive shell that they were able to provide for Molly really helped her to stay in a comfortable, regulated state as she was faced with these significant challenges that are being described.
So Sarah, do you want to talk a little bit about feeding stuff?
Yeah.
We have slides that are going behind that you will have access to, and the conversation is really around that content. So we're just going to keep the conversation going and just kind of speak to Molly's feeding and swallowing challenges.
So, like, here's the state of child's health. So when Molly first came in, she couldn't manage her own secretions. She wasn't swallowing her secretions. One thing that helped with that, and Pam, you're going to talk about this a bit more, the passing mirror valve was something we used right away. Did she put on an event?
She did not. I think she was weaned off the vent shortly before she got here, but still required the tray for the reasons we were talking about before. There's a passing mirror valve. What that does, it's also called a PMD or a talking valve. It's a valve that is placed on the tray, and it changes the airflow. The airflow pattern. It starts passing into the upper airway and starts to give the child a sense of more of a normal airway. It forces a person to exhale through their upper airway. That's going to help with voicing as the air passes through the vocal cords. It also helps to normalize a swallow, guarding against aspiration, and it helps to restore some lost balance by closing up that open trach in the airway. I know we used that PMD on Molly at first. She didn't really tolerate that at all because it was such a different way of breathing, and she had gotten used to breathing through the trach. So she was only able to wear that for about, I think, a very short time, less than a half hour. Some of the things you look for when they're not tolerating is an increase in heart rate, increase in respiratory rate, more secretions, even emesis, and I think Molly had all of those on the first attempt. Sometimes the trach is just too big. We downsize that trach and very slowly, increasing just a little bit of time each day, she was finally able to tolerate the PNV during her waking hours, which certainly helps with speech and PT.
And so related to swallowing, once she started tolerating that better, she could manage her secretions better, and we could start some oral trials with giving her. We usually start with something really simple like applesauce or puree level and see how a person handles that. Molly struggled early on, and her injury was from choking, so it was very scary for her mom, I think, with all the trials we started out with. But and at 2 years old, you can't really give a patient exercises to work on because they can't follow those commands. So you work on different sensory things in her mouth and outside on her neck, and kind of helping to trigger a swallow, working on it that way. And once she started really tolerating that PMV, she did a lot better, and she didn't leave inpatient on a full diet. She could do level 1 purees, and I'm not sure if she still has a stomach tube or G-tube now, but I know she's eating most of her meals, as far as I know now. But she did leave on tube feedings, and after a brain injury, people need more calories, so that's kind of the tricky thing right away is they can't eat, but so they have to get the tube feeding all the time. And so Molly probably didn't really have a really big sense of hunger right away either because she was getting that tube feeding constantly. And think about eating, it's a complex task, and so the person has to be aware enough of what's going on with their mouth and what they're eating, so they don't choke. So if someone comes in at like range level 2 like Molly, you wouldn't just put something in their mouth. You have to wait until she was more aware and cognitively alert before we could start trying anything. And like organization of motor movements, that can be reflexive where people will start chewing. Molly did have kind of a munching movement right away, but it wasn't the pattern that we would typically like to see, so we had to work on that a little bit with chewing. And then the coordination, the biggest thing I think right away is breathing and coordinating your swallow. You have to be able to breathe to do anything. So the stronger your respiratory system is, the stronger your swallow is going to be. And that's, I think, definitely the biggest thing that way. As cognitively, too, with the calming strategies, when Molly was more calm, she definitely handled eating things better. Like I said, at her swallow study, she was pretty agitated because it was a new environment and she was unsure of things. But once she had something that was calming to her, like watching the Dora video, she was able to handle it just fine. You can help cue kiddos when you're getting ready for oral trials, just using tactile stim to cheeks, different sensory things, like maybe just dipping a spoon for different flavors, just to kind of give them a little bit of taste to get them started. And then definitely using a calm environment is a big thing. So then they're not distracted by things going on.
I think it's always so challenging to figure out what it is that's really motivating versus noxious or that kids don't like. What are some ways that you thought about that with Molly? I mean, or as you think about your population in general, how do you approach that when you how do you determine some of that piece?
But what they like.
What they like or don't like.
Right. A lot of times families will say, well, they liked this before, but sometimes, a lot of times it can be textures, coming back into chewing, working things that way. Or it could be they don't like the pureed foods, and they just won't have anything to do with it. So that can be tricky at times, but once you find one thing, you can kind of build on it. So maybe you'll add different flavor to it. So you start with peas, and they like those, so then you add carrots to it, that pureed, so it's all one texture, and then they can get used to it that way. And then you can build on it otherwise by textures, by maybe having them smashed rather than whole peas.
It's usually a small step approach. I mean, you don't make big changes very quick because with that type of with our population, that's just where things are at. But it's subtle changes mean a big difference to our kids.
And also, after an injury, some kiddos start to have an oral aversion, so they don't want anything going near their mouth. They don't want food they liked before. Sometimes that could be related to being intubated. It could be just a lot of overstimulation, but that can lead to other issues. There could be gagging, throwing up, or it could be physiological as well.
Yeah, so when we think about successful discharge planning in the case of Molly, I mean, it involves aspects, well, all the cases do. But in Molly's case, it involved family, caregiver education, and training. And we've heard a lot about the type of intervention she had and how critical parent involvement and training was in her outcome. Another important factor in successful discharge planning is outpatient facility selection. Where are they going to go? What's their home community, and what kind of rehabilitation services are available to them? Often direct communication between the rehabilitation therapist that's been working with the child and the therapist that's going to be working with them next is critical, as well as cross-discipline, OT talking to PT talking to speech. You know, all of that is a critical component of making sure that the discharge planning is going to be successful. Understanding then what equipments are needed. Just to do simple things like to take a bath, for eating, for any functional skill that the child might need. Understanding their equipment needs is a critical part in team planning involved with successful discharge planning. Referral again to outside sources, not only for rehabilitation but for educationally based services. Follow-up is critical. And making sure again that the whole community is understood as much as possible and that supports are put in place. For instance, oftentimes if a child discharges and they're going back to school, there'll be a transition period where our team will help the receiving school to help the other students be ready to approach that child, to ask that child questions so that the child can integrate back into their school environment as quickly and effortlessly as possible. So those, you can see in discharge planning, there's a lot of factors. So what we're going to do is show you a little video of Molly so that you can see her firsthand.
So Molly left about, her injury was about 3.5 years ago now. So this video that you're watching here was taken 6 months or a year ago. You can see she suffered a pretty severe injury and she still has difficulty working on holding her head up and initiating those steps and things like that. But she was able to decannulate. She no longer has her tracheostomy. Like Sarah mentioned earlier, she is pretty much eating most of all her foods now. Her family primarily transports her in a wheelchair, but she is working continued outpatient therapy here at Madonna, working on developing all of those functional skills. She goes to preschool, so working on walking, working on sitting and playing and participating in a normal daily activity that any preschooler kindergartner would do, and continuing to help the family process that and work through all of the challenges that might come up as she continues to grow and get older and develop new skills or challenges.
So we're now going to discuss Riley, who is, she came to us at 12 years of age. She had a traumatic brain injury. She was thrown from a vehicle and a left lower leg amputation. She also stayed with us about the same time as Molly did. Riley stayed with us 126 days on the inpatient side. She was riding her bike along a highway and was hit. She had multiple transfusions following being, she was transferred to the trauma center and received multiple transfusions. She came to us with a VP shunt, a feeding tube. She was severely agitated. Her change, her functional change from, I mean, she was a typical 12-year-old who was active in softball and heavily involved in her community and her school. And so her life was dramatically altered because of this scenario. She also, her dad had been deployed just prior to her injury. So mom stayed with us, and there was a lot of interaction that was happening with dad overseas while she stayed with us. So again, she came to us at a level 3 at admission. Would you take?
Yeah, so one of the things that was more challenging about Riley was that not only did she have a brain injury, but she had a lower leg amputation as well, and that just kind of added a little bit of more challenge to encouraging her to be mobile. Because of the way her brain injury manifested, she was very weak on the side that had the amputation, and the opposite limb had a lot of awareness sensory deficits, what we call apraxia and ataxia, so poor coordination, inability to manage awareness of where that leg was. So all of this, all of these things that happened to Riley kind of compounded, and she was very agitated. We worked a lot initially on just sitting and balancing, using a lot of different sensory stimulation to help Riley stay calm but be able to actively participate in therapy. Having that amputation changed her ability to begin getting up and walking right away. We weren't able to wait there on that leg. We had to wait until that wound was healed, and then she wasn't able to get fit for a prosthetic for several weeks. And then training with walking on that also changed her ability to balance, and it made it a little bit more challenging, and just added another component that we had to work through for that.
So what does communication look like while a child is transitioning through the levels of brain injury that we saw in Maryland?
And kind of one thing to consider too with like age, like Molly, we had to use a lot of pictures because she didn't have a whole lot of speech before her injury. Where Riley, when she was at the lower levels, we did use more pictures, but she could also use some gestures. And so earlier on, when she wasn't really voicing, we used some gestures and tried some switches that she could activate that would say yes or more for different activities that we would do. And maybe even pointing to different things like yes and no. Yes and no is a difficult concept kind of at that stage, but she was able to point to some things with a lot of cues. When she became more agitated at that level 4 stage, then she did a lot of yelling and was agitated a lot, so it was hard for her to focus to communicate on anything. But she did still activate a switch with repetition to say more and communicate that way, but she wasn't using speech until I would say about when she got to level 5, and then she was confused. It was hard for her to talk about herself. She didn't know what was going on, so you'd have to use a lot of orientation. And her mom was great with talking her through things and talking about her injury and helping with communication that way. But we did use a lot of kind of the low-tech stuff earlier on, and as she progressed, she was able to communicate her basic wants and needs, and then eventually more complex information as she got better.
So did Riley have a trach? And
She did come with a trach. The reason for her having a trach is a little different than Molly. She had developed an MSSA pneumonia, which is a sensitive to antibiotic type pneumonia, and had some respiratory complications with that. A big difference with Riley was that the trach seemed to be honestly more of a problem for her than a help. She had a really strong gag reflex, and she had a very strong cough. So we quickly went through the steps. In fact, I think we even skipped the P&V and went right to the cap, which what the cap does is it restores normal breathing completely. I think she had the cap on a day and she kept having emesis because the trach bothered her so much. We just took it out, and she was great. So you can kind of see the difference between one person, you really need it to help with therapies, and someone else, it didn't help at all. We needed to get rid of it, so people get transplaced for different reasons.
What strategies did you use when Riley was agitated?
So as Sarah mentioned, she did go through that very agitated Rancho 4 state. She stayed there a while. Scream out and call out, and sometimes no matter what you do when you're in that stage, they're just in that stage, and you just have to support them as they go through it. But there are things that we can do when somebody is very agitated. As I mentioned with Molly, I look at the environment. So can I turn down the lights? Can I warm up the room? Can I decrease distraction for her? I also look at the person, as I mentioned with Molly as well. With Riley, I would look at her. Is she comfortable? Is she having pain? Where is she positioned? And then I look at the task. So is it simple enough for her? Where Riley would present something very simple that she could have success with right away. One good example is the iPad. So as she was very agitated, all she had to do was reach up and touch the screen and get some kind of reward, whether it was music or a bright scene on the iPad. So that was fairly successful for her even during her agitated state. Another strategy is to find meaningful things. So Riley had a lot of life roles. She was a softball player, she was a student, she was part of a family. So when Grandma and Grandpa were here, we would use them, or if little brother could come to visit, or some of her friends, we would use them during therapy. Or even just showing her pictures, simple things of things that were meaningful to her. Stuffed animals, again, softball was a big theme for her. I also use daily routine things, so things that we've done over and over in our lives that come back a little bit more easily than some other things. So if Riley was very agitated, maybe we started just with washing her face. Something very simple that she's done over and over and over again. We worked to brushing her teeth, combing her hair, those simple daily routine things. And sometimes we did use the Snoozling room with her, which is a special sensory room that we have here at Madonna that has different lights and different sensory activities that we can use to help with state regulation, to help her calm, be in a better state for learning and participation in therapy.
So I guess if we look at her functional status, Riley's functional status at time of discharge, Riley progressed to completing self-care with standby assist, and somebody can jump in on this. She was completing mobility with a prosthetic, so she had gained use of a prosthetic, which was a process for her to experience first the discomfort on that, then going through the insecurity of learning to stand on that, and then eventually to master real ability to walk with that.
And doing that with an evolving sense of awareness and memory and recall.
Yeah, and another challenge that Riley went through too was that she had a lot of anxiety that was just part of, her recovery with the brain injury and lack of awareness of where her body was and her balance, and all of that played into, a little bit of an up-down progression with her stay throughout inpatient. And so learning to use that prosthetic, getting back into those daily activities like Kelly was talking about, whether it was just bathing or dressing or eating, but also one of the things that she loved that we mentioned before was softball, and that was something that was highly motivating for her, and an activity that she really enjoyed, that she could get back into. And when we would use those types of activities to promote more mobility or movement, she did better because she wasn't as anxious. She was comfortable in that role and participating in those activities. We continued using that in inpatient. We were able to take Riley on some outings to the Husker softball stadium, and she kind of became, she became very involved with the ladies softball team at UNL, and that was very helpful for her motivation to be walking and running and all those kind of things. She did progress through outpatient and our rehab day program as well, and continued making that process. It's not just an immediate stop once someone discharges from inpatient, but it's a continued growth and recovery years on. And I know even in the years post her injury, and since she's not doing outpatient here, Riley's families from Kansas, and so they obviously went back home at some point. She continues to go to camps in the summer for people with an amputation and engaging that way, and continuing to encourage her to push those boundaries and get back into those life roles ongoing.
So you can see how the integration of all aspects of a person's functioning really is incorporated into the treatment. For instance, with Riley, and Sarah had mentioned the heightened anxiety and post-traumatic stress is something that is just part of an experience like Riley had gone through. And the interventions, as you can understand, are all triggers that would be registering in her nervous system is increased threat, which because of the trauma is now more heightened to begin with. And by incorporating aspects of her life, the positive aspects, it just in a natural way helps in the resolution of some of the psychological and emotional components of her recovery through every step of the treatment program while she was inpatient as well.
One of the great stories about Riley is that when she was ready to go back to school and was finishing up at the Rehab Day program, which is not our immediate program, but the Rehab Day crew worked to help her build a presentation so that she could talk to school and answer questions before they're asked, if possible. And she was a beloved student at her school, and so they all knew of her accident and injury, and so it was something that everybody was very motivated about. So,
and that building of narrative is those of you in mental health know, is just a critical component of overcoming trauma. Being able to, in a comfortable way, manage the telling of one's personal narrative is a high level of resolution that we go for, and it's done in a very natural, integrated way in pediatric rehabilitation.
and I think it's important because by the time she left inpatient, she was nowhere near ready for that type of work. That was at the end of her Rehab Day stay. So she had another course of stay with our intensive outpatient program, and so she's advanced beyond what you're going to see on our video here.
So this video was taken pretty close to when Riley discharged. You can see she still needs some assistance for walking. She's a little bit unsteady. But able, man, she hit that ball. Walking through and using that motivation of being part of a softball team. One of the things that was kind of fun about Riley, her nickname from her softball team was Cherries, and so cherries were on everything. In her room, she would get tattoos and things like that. Her prosthetic was a cherry design, and so she really loved softball, and this was one way that she could really get engaged and kind of forget that she had an injury and really get back into doing what she was doing before.
You'll notice here at the end she kind of picks up, which speaks to the motivation not only of her team but then also her family and the way that her family would constantly cheer her on, so as well as her teams.
So I want to thank you. That's the end of our panel presentation, and now would be a time for any questions. I want to thank you again.